Hi, good morning, everyone. Today for Grand Rounds, we have Dr. Andrew Leuchter speaking with us about rTMS and the topic of neuromodulation. Yeah, if you have any questions for Dr. Leuchter, please use the Q&A button to submit it at any time. And just as an update, we will not be having Grand Rounds for the next 2 weeks, but we will resume again on October 20. And now I'll hand it over to Dr. Strauss to introduce this morning's speaker.
Good morning, everyone. It's really my pleasure to introduce my friend and mentor and colleague, Andy Leuchter, who is today's Grand Round speaker. As some of you know, Dr. Leuchter came to UCLA after completing medical school in his home state of Texas at Baylor in 1980. He did his residency here and a Robert Wood Johnson Clinical Scholars Fellowship and joined the faculty thereafter. Actually, I met him in 1987 when I was an intern, and he was one of the two attending physicians on our geropsych inpatient ward, along with Jim Spar, who many of you know. Andy has had an extremely productive scholarly career at UCLA, having authored over 150 peer-reviewed articles and spent much of his work doing clinical translational research on the neurophysiology of depression and its treatments. That has included a number of years working with EEG and the role of EEG in predicting and correlating antidepressant response. And in more recent years, Andy was the founding director and currently continues to lead our division of neuromodulation, which has focused on transcranial magnetic stimulation, the focus of his talk today. And although you've heard a lot about TMS for depression, today Andy will be speaking about emerging new uses, including in hard to treat other neuropsychiatric disorders. Dr. Leuchter?
Thank you, Tom, for your very kind introduction, and thanks to all of you for coming to Grand Rounds today. The official title of my talk is Beyond Depression, Use of rTMS for Difficult to Treat Neuropsychiatric Illness. rTMS was first approved by the FDA for the treatment of depression about 12 years ago. And during this time, it has gained increasing use in psychiatry. However, as a novel treatment over the past decade, it still has not fully come into the psychiatric mainstream. I believe that this reflects the fact that rTMS is still not widely understood by practitioners, both in terms of exactly what it is and how it works, and for what illnesses it can be used. So really, the subtitle of my talk today is 8 questions that you should be able to answer about rTMS at the end of this talk. My real goal here today is to try to address some of the very common questions that I hear from practitioners every week about what rTMS is and why they should be considering it as a treatment for their patients. And I hope that by the end of this talk, you will have increasing comfort in accessing this treatment, not just for major depression, but for OCD, chronic pain, and some of the other illnesses for which it can be of significant benefit. Before we get further into the substance of the talk, I just want to get into my disclosures. I have grants and consulting relationships from government, from a number of industry partners that are involved in developing novel neuromodulation devices for treatment of patients with depression and other illnesses. And now to the 8 questions. First, what exactly is rTMS and how does it work? Third, for what is it indicated? These indications are expanding really by the month. Fourth, how does it compare to antidepressant medication? A very common question. And another related question is, how does it compare to ECT? Not uncommonly when patients come to us, they say, I was referred for either rTMS or ECT. Which should I have? Next, when a patient has had rTMS, how long can he or she expect the benefits to last? Seventh, what are the off-label uses? And then finally, what is the future of this treatment? So first, what exactly is rTMS? Well, before we can get to rTMS, let's talk about what TMS itself is. This is where we introduce a single pulse of electromagnetic energy into the brain to stimulate a nerve cell and get it to fire. rTMS was in fact discovered when somebody found that they could put a pulse of electromagnetic energy into the motor cortex of the brain and actually produce muscle activity in an extremity. The therapeutic uses of TMS came later. This was discovered when people found that if you put in repetitive trains of pulses, that over time, this could lead to lasting changes in brain function. So rTMS is not just single pulses, but repetitive trains of pulses in multiple sessions. When you do multiple trains of pulses, you combine these together, this constitutes a single session. Each of the bursts of pulses is separated by an intertrain interval. And pulse trains can be either rhythmic, as slow as 1 pulse per second, or up to 20 pulses per second. When it was first introduced into practice, the most common frequency of stimulation, which is still very commonly used today, is 10 hertz or 10 pulses per second to the left dorsolateral prefrontal cortex. More recently, people have started using what's called patterned rTMS, where you introduce brief bursts that ride on a carrier wave, 50 hertz triplet pulses that are delivered on a carrier wave of 5 pulses per second. This is a more efficient way of delivering treatment that can be used to greatly shorten a treatment session. Now, what all these methods of stimulation have in common is that they are believed to affect neuroplasticity. High-frequency TMS, that is 10 hertz stimulation or intermittent theta burst, where the theta burst is delivered for 2 seconds with an intertrain interval of 8 seconds. These are both thought to be excitatory. And excitatory stimulation is thought to induce long-term potentiation in nerve cells. Conversely, low-frequency stimulation, that is very low-frequency 1 hertz stimulation or continuous theta burst, are inhibitory. And these are thought to induce long-term depression in the nervous system. And the theory of rTMS is that by applying trains of pulses day after day, week after week, we are essentially rewiring the brain. Excitatory stimulation, it is thought, can lead to new enhanced connections. Inhibitory stimulation may, in fact, lead to decreasing some aberrant connectivity in the brain. Now, in order to understand rTMS treatment, you have to really start to think about this similar to medications. That is, like drugs, rTMS has doses. There's the intensity of the pulses, the location of the magnet, the number of pulses per session, and the number of treatment sessions. The first thing is, how intense do we have to make the pulses? Well, for this, the first thing we do is determine what's called the patient's motor threshold. We take an electromagnet, put it over the left motor cortex. You remember the old thing from medical school about how the left side of the brain controls the right side of the body? So when we put in the pulses in the right location at the right intensity, we actually get nerve cells and motor cortex to fire and can see motor activity in the right hand. When we induce this with about half the pulses, that is called the motor threshold. And that is the intensity to which all treatment is keyed. In general, effective treatment requires 100 to 120% of the motor threshold. Of course, after we've determined the motor threshold, we move the magnet forward to commonly left dorsolateral prefrontal cortex, a mood-regulating area of the brain, and deliver the treatment there. A course of treatment usually consists of 36 sessions. In the case of 10 hertz treatment, about 3,000 pulses per second. In the case of intermittent theta burst, about 1,800 pulses per second, 1,800 pulses per session. These are, if you do this for 36 sessions, these are generally effective courses of treatment. I talked about the efficiency of theta burst. Again, we started off with 10 hertz treatment. A full session of 10 hertz treatment takes up to about 40 minutes. You can, with using some of the newer forms of stimulation like theta burst, get a treatment session down to as little time as 10 minutes. So it can be much more efficient. It doesn't work in everybody, but when it does work, it can greatly shorten the burden of a long treatment session. So exactly how does rTMS work? I could give a whole lecture on this alone. We're not going to go into this in any detail, but I will say that we actually know more about how rTMS works than we do about medications. When you give a patient medications, they go everywhere in the body, throughout the brain. We're not really sure where they're working. For rTMS, however, we know where the treatment effect has to start. It's right under the magnet. And you can actually use fMRI or quantitative EEG to track the spread of pulses through the brain. The therapeutic effect starts at the treatment site, but it rapidly spreads through brain networks. And multiple treatment studies have shown that changes in connectivity involving the treatment site are associated with treatment response. There's one recent study that was just published earlier this year that compared active TMS to sham TMS here in the upper right panel. And you can see that active TMS led to global changes in connectivity that were not seen with sham TMS. And in the bottom panel, you can see that there was a fairly strong association between the degree of increase in connectivity involving the left dorsolateral prefrontal cortex and the degree of clinical benefit on the Hamilton Depression Rating Scale. So let's move on from how rTMS works and exactly what it is and talk about for what it's indicated. So as I mentioned earlier, 12 years ago, this became indicated for the treatment of major depressive disorder, and then much more recently for the treatment of obsessive compulsive disorder. About 2 to 3 weeks ago, it was actually FDA approved a new indication for smoking cessation. Now, in general, these indications specify that rTMS is indicated after the patient has had an adequate trial of medication and has failed to receive adequate benefit from a course of medication therapy. Now, despite the increasing number of FDA indications, major depression remains the only indication that is widely covered by insurance and Medicare. And despite the fact that the FDA says you only have to have failed one antidepressant in order to qualify for rTMS, most payers require multiple medication failures as well as generally psychotherapy failure before they'll approve a course of rTMS. So now on to the next question. How well does rTMS work compared to medication? Well, first, how well does rTMS work in general? In general, rTMS has been shown to be superior to sham in controlled trials, with occasional exceptions. For example, there was a large VA multi-site cooperative trial that came out last year that was a failed study, but in general, the response rate to rTMS for depression is between 15 and 59%, remission 14 to 41%, with the number needed to treat to show benefit between 3.4 and 6. So it is a moderately effective treatment that compares very favorably to what you would see in medication treatment trials. With adequate dosing and duration of treatment, that is 20 to 36 sessions, sufficient pulse numbers in a session and intensity of stimulation, the response rates generally are 40 to 59% and remission rates between 30 and 41%. Now, these rates really are, seem good, but nothing to write home about until you recognize that all of the patients entering these trials have failed to benefit usually from several antidepressant medications. So this is a fairly treatment refractory group in which we're seeing these response and remission rates. What you see here in the figure on this slide is a pooled analysis of 11 clinical trials from a total of more than 1,100 patients. And this showed that about 2/3 of the patients got substantial benefit from rTMS. A little bit more than 45% of the patients had a good clinical response, that is at least a 50% reduction in their depression rating scores. And another 1/5 of the patients were partial responders. They had between 25 and 50% improvement. Now, it is important to note that in most of these studies, the patients were receiving both rTMS and medications, and in some cases psychotherapy. So a lot of these are real-world studies that were in the kinds of patients that you'd be referring for rTMS treatment at UCLA or to another practice. Now, to the question of how well does rTMS work compared to medication, there really have been very few direct comparisons. rTMS is a costly treatment to perform. Patients have to come in daily for treatment for at least 6 weeks, so there just have not been a lot of head-to-head studies. I'm showing you here data from the largest control trial. This was a study performed at 18 sites in Europe, double-blind sham control trial where they enrolled 170 patients, and they were assigned to 3 groups, either those who were getting active rTMS with venlafaxine, active rTMS with placebo drug, or sham rTMS with a venlafaxine dose. And the mean dose of venlafaxine in the study was about 180 milligrams, so it was a pretty good dose of venlafaxine. The dose and duration of rTMS was adequate in this study. There were 6 weeks of treatment, a total of 30 sessions. And as you can see here in the figure on this slide, there was no difference in the 3 outcome groups. That is, whether the patients got rTMS with sham with placebo drug, they got active venlafaxine with sham TMS, or the combination, the scores came down about the same in all 3 groups. So this is, fairly persuasive evidence that the benefits of an acute course of rTMS compared very favorably to that of a course of a commonly used antidepressant medication. Now, I think that giving you a broader view here, we can take a look at how rTMS compares to some of the outcomes in sort of a real-world practice. This was a larger study that was performed, a year-long study looking at patients who were treated with rTMS. And you can see here that in this particular study, overall, with a good-sized sample, about 41% of the patients had a good response to rTMS, and more than a quarter of them went into remission. The interesting thing that I want to point out here is that as opposed to medication, there really does not appear to be an effect of the history of treatment resistance on rTMS treatment outcomes. That is, if you take a look here on the right-hand side of the slide, whether these were patients who had low treatment resistance, that is, they'd only failed to benefit from 1 or 2 antidepressant medications, or if they had high treatment resistance, that is, they failed to benefit from 3 or more antidepressant medications, the response and remission rates were about the same. And that, I think, is one of the unique things about rTMS. That is, when you get to higher degrees of treatment resistance, you still see good efficacy in rTMS. And that's made a little bit clearer here by this meta-analysis comparing rTMS outcomes to the outcomes from the STAR-D study. Now, I want to emphasize, this is not really a true meta-analysis. This was the STAR-D data compared to some pooled rTMS treatment outcome data stratified by medication resistance. So what STAR-D showed us was that for the first medication, the patients go into remission just about under a third of the time. And then when you switch to a second medication, you pick up an additional group of patients who are going to go into remission, perhaps 20%. And then when we go to the third and the fourth medication, we're getting to the point of diminishing returns. That is, perhaps 15% for the third medication, under 10% for the fourth. Contrast this to what you see with rTMS. For the second medication, the third and the fourth, the outcomes from rTMS, the remission rates are probably at least as good, if not better, than what you would see for patients who have failed to benefit from multiple medications. So I think one of the take-home messages here is that rather than subjecting patients to a third, a fourth, a sixth, or an eighth antidepressant trial, we should be thinking earlier about rTMS because it may in fact be of earlier benefit to our patients. Now moving on to the next question, how does rTMS compare to ECT? Now once again, there have been few valid comparisons here. Generally, the studies have used TMS at non-optimized treatment parameters. They've used high frequency left or low frequency right versus a variable number of unilateral or bilateral ECT treatments. There was a good meta-analysis of 9 studies that showed that overall ECT had an advantage over rTMS, 64.4% response rate versus 48.7%. Similarly, higher remission rates for ECT versus rTMS. If you looked only at the patients who got high frequency left, there was a little bit less of an advantage, but still an advantage for ECT over rTMS treatment. More recently, however, what's been looked at is subgroups of patients who get ECT. First, one recent study from last year from Yuan and colleagues at Butler Hospital in Rhode Island showed that whether patients had had ECT and responded to it or not before, that didn't really seem to be a predictor of whether they were going to respond to rTMS. That is, ECT treatment history seems to have very little relationship to how somebody's going to do in a course of rTMS. There have now been 2 studies that have compared specifically psychotic and non-psychotic depression patients in terms of ECT versus TMS treatment outcomes. And as you can see here in the top panel, while there is an advantage for ECT in general over rTMS, in the next panel here in the middle of the slide, in fact, that advantage goes away if you look exclusively at the non-psychotic patients. That is, outcomes of patients with non-psychotic major depression appear to be just as good as they are for TMS as they are for ECT. That is, for high-frequency left treatment, response rates of 51.4% versus 52.5% for ECT and rTMS, respectively. Here in the bottom panel, you can see there is a large efficacy gap for psychotic depression. So I think a major take-home here is that if a patient has psychotic depression, you definitely want to refer for ECT. For non-psychotic depression, TMS is a very good treatment alternative to consider to ECT. There are significant differences in the burden posed by ECT and TMS. TMS is in many ways a less convenient treatment. There are a greater number of total visits, 36, 5 days a week for 6 weeks at least. Patients complain a bit more of discomfort with TMS because they are awake for the treatment session. So initially there is more discomfort at the treatment site. However, TMS treatment sessions can be much briefer than ECT treatment sessions. And of course, there's no anesthesia or restrictions on activities posed by going through a course of rTMS treatment. There's no difference in overall acceptability of TMS to ECT in multiple treatment trials. That is, the pluses and the minuses seem to balance out for a lot of patients. Although it is pretty clear that ECT is associated with greater impairment in memory, verbal fluency, and executive function. As you can see here in this study, in a study of 30 patients with non-psychotic major depression, there was significantly greater impairment in anterograde memory, in retrograde memory, and subjective memory in patients getting ECT compared to those who got TMS or compared to what happened in control subjects who went through sham ECT. So if cognitive impairment in the short run is an important factor for patients, if they don't want to have any short-term memory impairment or impairment in function, then TMS does offer certain advantages for those patients. There is one area in which TMS may offer another advantage. That is a study that we performed here that my colleague Juliana Corlier reported in the Journal of Affect Disorders just earlier this year, was that TMS treatment was associated with significant improvement in executive function in those patients who did well with TMS. And in fact, TMS may be the only treatment that offers this advantage. That is, this has not been generally seen in patients who go through medication treatment for depression. Now, obviously, this is the first study of its kind to show this benefit, and this needs to be replicated in future studies, but it does show that there may, in fact, be some cognitive enhancement that comes from TMS treatment. The next question is, how long can we expect the benefits of a course of rTMS to last? There has been only one good long-term follow-up study of rTMS treatment outcomes, and this one followed patients over the course of a year after the end of their acute course of rTMS. Now, in our practice, we've seen patients who've maintained the benefits of treatment for multiple years. In this study, which was as I said, the only one ever done by Dave Dunner out of the University of Washington, they looked at more than 300 patients over the course of a year after they completed treatment with follow-up every 3 months. And what they found was that overall, the benefits of a course of treatment lasted a year in 70% of the patients. Now, they broke up the patients into 4 outcome groups. Those who failed to benefit from treatment, that is, they got less than a 25% benefit from a course of treatment. Those who had partial response, 25 to 50%. Those who had a complete response, more than a 50% benefit. And then lastly, those who remitted essentially got over their depression completely. They found that response to rTMS tended to be quite stable over time, but that about half the patients who did respond needed to get some additional treatments over the course of a year, sort of booster treatments, if you will. The number of treatments varied quite a bit. Some patients needed another full course of treatment to stay well. For others, it was just one or a few treatments every few weeks or months. On average, if patients did need additional treatment, it was about 16 sessions over the course of a year. Another interesting finding from the study, you can see in the top line here, the patients who are marked with a square. That is the non-responders to benefit. Even these patients who at the end of an acute course of treatment seem to have very little benefit, in the first 3 months after the end of a course of rTMS, they actually had on average about a 20 to 25% improvement in their depressive symptoms. Now, what this represents is unclear. Is it a delayed response to rTMS treatment? Is it the fact that their brains were somehow sensitized to medications, to respond to medications from which they did not benefit before? There have been a few competing theories about this, and the underlying cause is not clear, but we do counsel our patients that even if they don't get an immediate benefit from treatment, they may see some benefit emerging after the conclusion of course of treatment, and if they obtained some benefit, they may obtain more. Another interesting finding about rTMS is that the results tend to be highly reproducible. If a patient benefits in one course of treatment, if they come in again needing additional treatment, they're highly likely to benefit from the same parameters again, and frequently will get the benefit more quickly. Now let's move from the on-label uses to the off-label uses of rTMS. Exactly what we treat depends on which brain circuit we're trying to localize and to which circuit we are administering the stimulation. There are a number of circuits in the brain. I'm just going to highlight 3 of them here. Obviously, for the treatment of depression and anxiety, we're looking primarily at the limbic system of the brain, and our initial usual treatment target is dorsolateral prefrontal cortex, most commonly on the left, sometimes on the right. However, there are other circuits we can target as well. So, for example, if we want to treat a movement disorder or treat chronic pain, it turns out that targeting motor circuits can be extremely useful for this. More about that in a moment. And lastly, if we want to look at cognitive functions or memory, targeting one of the associative circuits of the brain can be useful as well. So exactly where we target stimulation on the brain depends on what symptoms we're trying to treat. As we tend to say, there is a lot of real estate up there. And by tailoring stimulation to the individual's patient's symptoms, we can frequently help with a variety of different problems. Our primary mood target is left dorsolateral prefrontal cortex. But by moving the magnet more to the frontopolar regions of the brain, we can treat symptoms of obsessive compulsive disorder or recurrent intrusive negative thoughts. If we move more to the motor cortex of the brain, we can treat movement disorders, and interestingly, by stimulating over motor cortex, we can commonly help chronic pain complaints in patients with neuropathic pain or fibromyalgia symptoms. If we move down a little bit further, more to Heschel's gyrus and primary auditory cortex, we can treat symptoms of tinnitus, and in patients with treatment-resistant auditory hallucinations in schizophrenia, frequently help to reduce the intrusiveness, the occurrence, or the bothersomeness of auditory hallucinations. We have recently completed a study where we are looking at MRI-targeted treatment over parietal cortex and have found that we can help older adults with memory loss by targeting areas in parietal cortex. But the bottom line is there are many areas that we have not yet explored, and we don't really fully know what all the potential treatment targets are. This is a very important emerging area of research where neuroimaging is working hand in hand with neuromodulation to explore different approaches to treatment. Now, as I mentioned earlier in the talk, OCD has moved from an off-label treatment just within the last few months to an on-label treatment, largely on the basis of the data presented in this study. This was a good-sized study, 99 patients with OCD who were treated either with rTMS or with sham. The particular form of TMS in the study was called deep TMS, administered with a particular device, the BrainSway TMS system. Now, this is called deep TMS. In reality, it's more broad TMS. It goes a little bit deeper into the brain. Most of the pulses with most of the systems go down only about 2 or 3 centimeters. With the BrainSway device, perhaps it goes down to 4 centimeters. But what it does is to stimulate a much larger area of cortex. And in this study, they administered stimulation to medial prefrontal cortex. They did this in conjunction with an individualized symptom provocation protocol and treated patients for 6 weeks. They assessed response with the Y-box scale from baseline to the end of 6 weeks of treatment. And what they found was that there was a significant reduction in severity of OCD symptoms, was much greater with active treatment than with sham, with response rates of about 38% of patients. So it's really a pretty good signal for an illness that is challenging to treat. Now, this is one particular device that most practitioners don't have in their office. And this was also a protocol that was done with symptom provocation. What we wanted to explore in our practice was, could we get similar findings using a more traditional rTMS device, but with a novel multi-site treatment protocol? So here are some results from a study that Reza Tadayan-Najad in our group has recently submitted for publication. This is just a pilot study of 7 subjects with moderately severe OCD with comorbid MDD. As you can see, these patients had fairly high Y-box and IDS depression scores. We did multi-target treatment. We treated patients with theta burst stimulation at the dorsolateral prefrontal cortex and then followed that up sequentially with stimulation, inhibitory 1 Hertz stimulation over the supplementary motor area. And in this new treatment approach, we actually got a very good response. Over the course of 6 weeks, we saw response rates both in depression and OCD between 40 and 50%. Obviously, this is a small open label trial. These results need to be interpreted with caution, but we're very encouraged by Reza's early findings here, and we're providing much more treatment for OCD with comorbid depression these days. Another area that we're seeing a significant increase in activity is that in rTMS for chronic pain. Now, as I mentioned earlier, we've had good results, and there have been good results reported in the literature, stimulating for chronic pain over M1, the primary motor cortex. And in multiple studies, at least half of the patients receive at least a 30% reduction in their symptoms, their chronic pain symptoms, whether they're due to neuropathy, fibromyalgia, osteoarthritis, or other chronic pain conditions. The graph that you can see here in this slide is from patients with post-herpetic neuralgia, where you can see that active stimulation resulted in a significant reduction in pain symptoms that was much greater than sham. And in this study, the benefits of treatment lasted for many months. The other good news was that by extending the treatment period, in fact, the benefits of treatment could be extended as well. So again, what we find is that many of our depressed patients come in with chronic pain that either preceded the depression or results from the depression. And we do, again, a sequential treatment approach where we place the magnet over dorsolateral prefrontal cortex and then move it back to the primary motor cortex to administer additional treatment to help both with mood and with pain complaints. Our research has shown, and this is a project that's been led by Juliana Corlier, again in our group, where Juliana has identified a novel pain response network. And what we are exploring now is whether if we treat at critical hubs of this pain response network, whether we can be of more benefit to patients with chronic pain. This is a manuscript that is now in submission and one that we're following up on with research in our group right now. Now, I want to move from some of these particular illnesses we're talking about to the general concept of how can we help more patients get well more quickly? And this brings up the concept of accelerated TMS. Now, a total course of rTMS treatment consists of about 90,000 pulses. So, of course, somebody did have the idea of what happens if you put somebody in a chair, you put the magnet on their head and you simply administer all 90,000 pulses at once without a break. And two things happen. Number one, they commonly get a headache. But number two, it doesn't improve their mood. So it appears that you need to space the treatments in order to induce neuroplasticity and get the therapeutic benefit. TMS has traditionally been a once-a-day treatment, but the question is if we do rTMS treatments not just once a day, perhaps 2, 3, or more times a day, but space them out a bit, are the results additive? And it turns out that, in fact, yes, if you space the treatments anywhere from 20 to 60 minutes apart, the results of an accelerated, compressed course of treatment can be quite comparable to what you get from daily treatment spread out over 6 weeks. The first person to try this was my friend and colleague Paul Holzheimer at Dartmouth, who looked at a sample of 14 patients who he treated with 15 rTMS treatment sessions a day for just 2 days. So he got a whole treatment course in just 2 days. These were moderately severe patients, all were medication resistant. He assessed them over 3 days and then at the end of 3 weeks and 6 weeks, and saw that really upwards of between 35 and 50% of the patients had a good response with good remission rates as well. So this stimulated really a lot of interest in this concept of accelerated treatment. There have been a few studies of this over the years. It's very labor intensive, as you can imagine, getting somebody to come in and basically sit with you for the day while you repeatedly treat their symptoms. One recent study that was very interesting was done by Nolan Williams at Stanford, where he looked at 20 depressed inpatients who received 10 daily ITBS treatments, theta burst sessions, for 5 days. This was a very labor-intensive, sophisticated study where they did neuroimaging MRI-guided treatment, and they obtained a remission rate, not just a response rate, but a remission rate of more than 90%. Now, one has to be cautious in drawing conclusions from the study because this was an open-label study, and as we all know, patients in open-label studies tend to report more benefit than those in controlled studies. However, this has generated a lot of interest, and we actually now are conducting a study of this now ourselves here at UCLA that John Lee in our group is performing in the Resnick Hospital across the street. So we're looking at patients with major depression or those with acute suicidality who may or may not have depression, and trying to treat these patients with rTMS. All patients are receiving 5 daily rTMS treatments. We're doing, again, a novel multi-target approach where we're treating both at the left dorsolateral prefrontal cortex and in the frontopolar regions of the brain. And our goals are to rapidly eliminate depression, but also to significantly reduce suicide risk and hopefully to shorten the length of hospital stay. Because of the COVID pandemic, John had to take a break on this study, but we're hoping to get going again in the near future and to have some results on this, hopefully in the new year. I also want to touch briefly on the topic of memory enhancement. I alluded to this earlier, that by using fMRI to target some areas in the parietal cortex, we can find areas that have strong connections to the hippocampus. And my group, in collaboration with Nanthia Suthana's group, Nanthia has appointments both in psychiatry and in neurosurgery, we've looked at a group of older adults with MCI, mild cognitive impairment. In this study, we have treated these patients. We've done baseline memory testing and done baseline fMRI to look at bold signals in deep memory structures in the hippocampus and the brain. We then administer 5 days of theta burst stimulation, either active stimulation or sham, to this parietal target. And what we found was that really after only just 5 days of stimulation, as you can see here in the upper panel, the group that got active stimulation, in fact, had significant enhancement of memory performance compared to those who were treated with sham stimulation. Even more impressively, if you take a look at the lower panel here, you can see that there was enhancement of the fMRI bold signal in the hippocampus in the patients who got active stimulation that was related to the degree of memory improvement. I'm pleased that Nanthia and I recently received a grant from the NIA to study this prospectively over the next 5 years in older adults, and we're hoping eventually to apply this to patients suffering from dementia as well. So what else is in the future of rTMS? Well, what we need to do, in addition to getting rTMS to work more quickly with something like an accelerated approach, is to get it to work better for more people. These are some data in an interesting study by Paul Fitzgerald. As you can see here on the right-hand side of this slide, there is a substantial group of individuals, upwards almost half of them, who have a robust response to rTMS. Lots of responders, and in fact a large group of remitters. However, there is also a second group, which you can see here on the left, that obtain very limited benefit from rTMS. There's this classic bimodal response. Now, we and others interpret this as, for the patients who are getting benefit, we're successfully engaging the target brain network. For the other patients, we may simply not be engaging the target. And what we're working on is better ways to engage brain networks to get more patients well. To take this group on the left, who are not seeing significant benefit and shift them over toward the right. In an article that Juliana Corlier and I published back in 2018, we talked about this concept of precision rTMS. Right now, we take a one-size-fits-all approach. We stimulate patients at left dorsolateral prefrontal cortex with standard frequency of 10 hertz or intermittent theta burst. But our work using combined TMS EEG, actually doing EEG recordings during TMS, suggests that each person may have a resonant frequency of their brain. And if we're able to stimulate, identify, and administer treatment to stimulate at that frequency, they may get better results. So we're aiming to use this resonant frequency approach in a prospective treatment study. And we're optimistic, looking at some of our earlier pilot results, that we may be able to get remission rates up closer to 80% of the patients. We're hoping to have some encouraging results from that study in the coming years. Another approach has been TMS augmentation strategies. These are data from an article that John Lee and our group just published in the Journal of Affective Disorders. So we looked at a group of 139 individuals who came in and received a standard 10 hertz treatment approach, 10 hertz treatment administered to the left dorsolateral prefrontal cortex. This was a measurement-based care strategy where after 10 sessions, we looked to see which of the patients had gotten at least a 20% improvement in their depressive symptoms. This turns out to be a pretty good predictor of who's going to do well. And consistent with the prior literature, you can see here in the bottom line in this graph, those individuals who got at least a 20% improvement at 10 treatments went on to do very well in treatment. They had more than a 60% benefit in symptom reduction on average. Conversely, in the top line in this graph, those who did not get that 20% improvement, but nevertheless continued with 10 hertz treatment, did not do very well. However, for those who did not get that 20% improvement, we assigned them to many of them to two other groups. One, to receive sequential bilateral treatment. That is, treatment first at left dorsolateral prefrontal cortex, followed by low-frequency treatment at right dorsolateral prefrontal cortex. And you can see that group did a bit better here, this dotted line, where they had a slightly better, but not significantly better symptom reduction. John then employed a novel, what we call a theta burst priming strategy, where he administered a brief 600 pulse course of theta burst before the 10 hertz treatment. And in the dotted line with the diamonds here on your graph, you can see this group had significantly better outcomes that were starting to get closer to the group that did well with 10 hertz treatment to begin with. So we're hoping that this kind of measurement-based care strategy, where we adapt our treatment based on how patients are doing, may also lead to better target engagement and symptom reduction over time. Another augmentation strategy is to use medications. We published an article last year that showed that most medications didn't have much effect on TMS treatment outcome. Most of our patients receive psychotropic drugs along with rTMS, but that those who received benzodiazepines actually had slightly worse outcomes. One of the other interesting findings was that patients who were getting stimulants concomitant with rTMS actually tended to do a bit better. And Scott Wilkie in our group has now looked at these data more closely and has shown that certain stimulants may be associated here with better, more rapid onset, perhaps, of TMS treatment benefits and better outcomes at 6 weeks. So we're looking to undertake a prospective trial of stimulants versus placebo along with rTMS to see if this does prospectively lead to better treatment outcomes. Now, there are a whole host of these neuromodulation treatments that are out there for different illnesses. Not only rTMS, but also trigeminal nerve stimulation and other non-invasive battery-operated devices that can sometimes be used in the home. So to try to make all of these treatments more accessible to more patients for more conditions, just a few months ago, we started up our Neuromodulation Clinic here in the Semel Institute. We were fortunate enough to be able to recruit Kate Martyr to the faculty, and Kate is the medical director of our new clinic. The mission is to expand access to non-invasive neuromodulation treatments for these chronic, difficult-to-treat illnesses. We're looking at depression and OCD, but also chronic pain, tinnitus, and other conditions. We're looking to increase access to TMS, to TNS, trigeminal nerve stimulation, to peripheral nerve stimulation, bright light therapy, and for those patients who don't do well with an acute course of TMS, also to potentially look at oral ketamine administration. So in conclusion, what can we say about rTMS now and in the future? Well, first, I think the data make pretty clear that rTMS may have benefits comparable to antidepressant medications, particularly for those patients who are multiply treatment resistant. So rather than thinking about a third or a fourth antidepressant medication, we should be thinking about rTMS because the response rates may be better. The data also suggests that high-frequency left rTMS and potentially theta burst as well may have benefits comparable to ECT for patients with non-psychotic major depressive disorder. The risks and benefits of TMS and ECT can and should be weighed to determine what is going to be best for the individual patient. Next, by targeting different brain networks, it is possible to treat OCD, chronic pain, tinnitus, and a host of other difficult-to-treat neuropsychiatric illnesses. And lastly, a number of new treatment strategies offer the possibility of enhancing outcomes and accelerating treatment response for rTMS. Now, in conclusion here, I want to thank you, first of all, very much for attending today's talk, and also to say that, I have the pleasure of getting up here to talk about all the wonderful work that we're doing in the neuromodulation division, but this is very much a team effort. I've acknowledged a few of my collaborators and faculty colleagues in this talk, but as you can see here in this next slide, we have a whole treatment team. We have a group of dedicated and talented technicians and clinical administrators who make all of this possible, as well as a faculty group that are working in our rTMS service, both in Westwood, our new Pasadena clinic, and in the Neuromodulation Clinic as well. So I'm very grateful to all of them for making all this fantastic work possible. And once again, many thanks, and we're happy to take questions.
Hi, thanks so much, Dr. Leuchter. We have a few minutes for questions, and we've had quite a few questions come in, so I think there's definitely a lot of interest in this topic. One of the questions was about the relationship of TMS to psychotherapy. They asked, since TMS has benefits on enhancing cognition and neuroplasticity, are there any studies showing continuing psychotherapy may have additional benefits during TMS versus treatment with TMS alone?
That's a great question, Jonathan. Two thoughts on that. One is that, excuse me, in Europe as opposed to in this country, TMS is commonly done simultaneously with cognitive behavioral therapy. And they've reported some very impressive response and remission rates, upwards of 80 or 90%. Most of these, again, are open label studies, so you have to interpret results with caution. But it certainly does suggest that some of the time during TMS may be well spent on shaping cognitions and perhaps dealing with some of the patient's ongoing negative thought patterns. The other thought on that is that most of the patients we have suffer from chronic unremitting depression. So even when we've treated the acute mood disorder, they're not necessarily convinced that they're all the way well. They remain anxious about recurrence of symptoms. And commonly we do refer patients for psychotherapy during or at the conclusion of a course of rTMS really, from our perspective, to help lock in, consolidate the benefits of treatment.
Very helpful, thank you. Another question was looking specifically at results for bipolar disorder, either depression or mania, and looking at some of the data there.
Right. Yeah, so there has not been a lot of study of bipolar disorder. We certainly have treated a number of bipolar patients. I should say, actually, by way of starting that topic, that you know something is an effective antidepressant therapy when you can, in fact, induce a manic episode as a result of administering it. And we have, in fact, seen occasional patients who start to cycle or start to become hypomanic. One of the advantages of rTMS as opposed to medication therapy for depression is that if we start to see any signs of hypomania or cycling, we can in fact dial down the treatments and get things under control rapidly. We've treated a number of patients with bipolar depression over the years, have found just anecdotally that the treatment works very well for bipolar depression. There recently was one study that Scott Aronson at Shepherd Pratt, friend and colleague, has concluded that shows actually good efficacy for bipolar depression, but there's not been a huge amount of study, and of course, treatment of bipolar depression still has to be considered off-label because it's not within the narrower FDA indication for the illness.
Got it. Okay. We have time for maybe just one more question. A question just came in about age limitations. Is there any utilization of TMS for children under the age of 18?
Okay, that's another very good question. We've never done rTMS in anybody over the age of 100, and we've never done rTMS in anybody under the age of 14. We have had some referrals of children and adolescents. We make clear to families that this is an off-label treatment option, and that we traditionally recommend more standard approaches for child and adolescent depression, but we have had good success in some families that have chosen, some patients who have chosen to pursue rTMS for adolescent depression, and have found that the results not only are good acutely, but also can be effectively used repeatedly if the illness.
All right. Well, thank you so much. We're just about out of time, but I wanted to say thank you for going over the topic with us, and thank you all for joining us this morning for Grand Rounds.
Thanks, Jonathan.
Yes. Bye.